Good evening, doctors. A warm welcome on behalf of Shield Healthcare. I'm Dr. Prachi from Shield Healthcare. And let us start this today's mix back webinar. I'm very happy to have all of you. It's a privilege and honor to have you all in this evening webinar. Let me introduce Dr. Ritu Santwani ma'am, who is the organizer and speaker. Ma'am is infertility specialist and founder and CEO of 360-degree Healthcare Studio. Also co-founder of ma'am and board member of SWWC. Our guest of honor is...
The first chief guest.
Sorry, ma'am. Sorry. Our chief guest is Dr. Tarini Taneja ma'am. Ma'am is chairperson of Delhi ISA, chairperson Breast Committee FOXI 2013 and 15, international member of FIGO Working Group of Breast Diseases, and executive member of DMA. Ma'am is recipient of many awards like Bharat Gaurav Award, Gold Icon Award, Inspiring Women Award, Lifetime Achievement Award, and also award by Government of Uttar Pradesh for family planning. Ma'am has also honored by Dainik Jagran Muzaffarnagar. So thank you, ma'am. Thank you for joining. It's a big honor for us that you are there with us. Over to you, ma'am.
Yeah. A warm welcome to our means मुझे बोलना चाहिए for all of us, the very favorite, the Dr. Tarini madam. Madam, thank you so much for joining us. I know madam is very busy for these days for organizing the program. So still I am very thankful that once I called the madam has accepted the invitation. Madam, from Pune I am sending you this roses to you. I hope this fragrance will reach up to the Delhi.
What a good gesture. What a good, great gesture.
Thank you, madam, for joining. Madam, we will take first your blessings, then we will introduce everyone.
Oh my God. So Ritu, what to say? There's so much to tell about you, but I mean, time is very short because we want to listen the speakers for today.
Yes.
The very, very important topics, Dr. Anand Java, Dr. Kishore Rajurkar, and also, I think, Anita Rajoria. So one thing to say, this platform has become very, very prestigious and internationally of repute. So everybody wants to join this platform. I'm really happy. I know Ritu for very long. She is my very, very loving friend, and everybody loves her. She is very good academician and very humble person and really friend of the friends. So many things to tell about Ritu. I think everybody must be knowing about her. And every day she's doing the updating ourselves and everyone around her. So I say one thing, knowledge, investment in the knowledge always rewards a lot. So even I love academics, and that's why I am very, very good friend of Ritu, because beside so many qualities, she keeps academic at the priority. So thank you so much, Ritu, for inviting me at this prestigious platform. And I'm really happy to be my guest of honor for today is also my loving friend, Dr. Neelam Gupta, and also Jyoti Banglowala. And I'm really happy to see both of them. And also all the speakers are good speaker for today. They are, ultimate in their field, and they all are my good friends. So thank you so much, Ritu, for inviting me for this prestigious platform of international review. I really bless you from my heart.
Thank you.
I love you. I bless.
Thank you, madam. Thank you so much.
Over to you. I want to listen all of them.
Yeah, thank you, madam. Thank you so much. Prachi, we can introduce our guest of honors. Dr. Neelam is not able to join. I've just called her. She is busy. She is not able to join. So please introduce Dr. Jyoti, madam. Yeah.
Yes, ma'am. Dr. Jyoti ma'am is there with us. Thank you very much, ma'am, for joining. Ma'am has around 26 years of experience. Vice President, Indore Ops and Gynec Society, till from 2022 till date. Secretary Indore Ops and Gynec Society till 2022. Interested in ethical.
Today my introduction is just I am Ritu's friend. This is enough. There are big speaker in front of me, so please.
Yes, thank you, ma'am.
Yes.
We have our speaker with us, Dr. Anand.
1 minute. We will take few words from Jyoti ji. Jyoti ji, thank you so much for joining. वो ज्योति जी के लिए भी ऐसे ही बोल सकती हूँ ना कि वो दोस्तों की दोस्त है. So thank you so much for joining and taking out your precious time. I know the persons who are contesting for the election, they are having a lot of pressure these days and lot of phone calls and lot of things they have to do. Still, they are accepting the invitation. That is also great. So we will take few words from you, Jyoti ji. Then we will proceed for the first talk. Yeah.
Yes, of course. And really, it is a very, I'm very thankful that you have connected me in this platform, the global prestigious platform. So I can, apart from my topic, this particular webinar, mixed webinar, when I saw Anand Jawar sir, Rajurkar sir and Anita, and I saw all the topics, it is a very humble privilege that I have got from you. And thank you very much, Ritu, for this. And I'm keen to listen all three speakers. And my dear Tarini madam, she is always there to support in each and every conference. Whenever she meets us, she always blesses. She is just like an elder sister to us. So namaste Tarini madam, and thank you Ritu for
my dear, all the best to you. All the
thank you, ma'am. Thank you. And now we should go for the academic lecture, because all three lectures are so good actually.
Yes. Prachi, give me 2 minutes. So warm welcome to all of my dear friends who have joined all across the geography. Friends, as we all know, knowledge is power and knowledge always increases by sharing. By this motto, I started this series long back in the lockdown period. And I'm really thankful to Prachi also. Whenever I call that Prachi, I need platform, she never says no to me. So Prachi, one credit goes to you also. I know in the initial days when I was telling Prachi, मुझे तो रोज platform चाहिए, मुझे आज ये करना है, मुझे आज वो करना है. So yes, but really everything matters for becoming the success of any program. And thanks to my dear friends who are joining all across the geography. A special thanks to the doctors who are joining across the globe. I have able to see some doctors have joined from the Egypt, some from Somalia, and some from the Bangladesh also. Lot of messages I'm already receiving via YouTube. So now, without wasting time, I will request Prachi, please introduce all three speakers, and then we will start the academic session one by one.
Sure, ma'am. Thank you very much.
Prachi, just a minute. I would like to say my good evening, hello to all the international, who are connected faculty, international faculty, or whatever, like the esteemed guest today. So good evening from India.
Yes, ma'am. Thank you.
It's over to you, Prachi.
Thank you, ma'am. Yes. We have our first speaker, Dr. Anand Jawar. Sir is fellow of CSCPI, also executive member. Ex-editorial board member of News and Views, CSCPI, life member of Indian Association of Sex Educators and Counselors and Therapists, life member of Indian Andropause Society, Indian Medical Association, and Indian Academy of Pediatrics. Would be speaking on responses of male and sexual responses. That's the topic. The next speaker is Dr. Anita Rajoria, ma'am. Ma'am is head of the department and senior consultant, Ops and Gynecology at Dr. Hedgewar Arogya Sansthan, Government of NCT, Delhi. Various affiliations, various achievements, lot of awards and honors, and many publications. So,
thank you, Prachi, for that nice.
I am so sorry, ma'am.
It's all right. It's all right. Thank you so much.
Okay. And our third speaker is Dr. Kishore Rajurkar. Sir is ex-HOD, OBGY, and minimal invasive surgery at Sanjay Gandhi Memorial Hospital, Government of Delhi. Also recipient of many awards, published many papers in national and international journals. So with this short introduction, I will hand it over this webinar to Dr. Santwani, ma'am. Over to you, Ma.
Thank you, Prachi. A warm welcome to our three esteemed speakers, Dr. Anand sir, Dr. Rajurkar sir, and my favorite Anita madam. A warm welcome to all of you, friends. So now we are, Dr. Samuel is also joined from the Africa. Welcome. So now, without wasting time, first we are taking topic one by one, and later on we can discuss our questions. So friends, before we some of you log out in between the sessions, so please lock your time for the 11th July 9 p.m. We are having a ex-FOC president Dr. Rubina Sohail with us on 11th July. A very interesting topic we are going to discuss. So for knowing the more details of the topic, stay tuned. I will be posting the flyer very soon. Over to you, Anand sir.
Okay, thank you. Just 1 minute, let me share my screen and I will
sure.
start my presentation. I am Dr. Anand Jhavar here. Thanks for kind introduction. And I am here to speak on male and female sexual response cycle. Human sexual response cycle. First, it was studied by William Masters, Virginia Johnson. Until then, everyone was clueless about what went on biological during intercourse, and lots of misinformation were there. So they studied 694 people who were able to reach orgasm during the intercourse under controlled laboratory conditions, and they divided into 4 phases. Excitement, when body begins to show signs of arousal. Plateau, sexual arousal increases and maintains, then orgasm. Climatic, release of sexual tension, and resolution, relaxation, and return to non-arousal stage. One minute, let me just brief down this. The sexual response cycle is a model that describes the physiological responses that occur during sexual activity. This model was created, as I told you, by William and this one. Now, this is the sexual cycle. The sexual response cycle refers to the sequence of physical and emotional changes that occur as a person becomes sexually aroused and participates in sexually stimulating activities, including intercourse and masturbation. Knowing how your body responds during each phase of the cycle can enhance your relationship and help you pinpoint the cause of any sexual problems. Sexual response has 4 phases. One is excitement. A person may arouse sexually by thoughts, fantasy, kissing, touching, or masturbation that leads to excitement and body gets ready for sex. Plateau, this is a stage of more intense excitement which extends to the brink of orgasm. Orgasm, it is the climax or peak or apex of the sexual response. In this phase, the tension that builds during the sexual activity is released in a series of muscle spasms, especially in the groin area and rhythm, and it sends a wave of pleasurable feeling through the body. This is the shortest phase of all and generally lasts only for a few seconds. The resolution, in this phase, body functions slowly, returns to a normal level of functioning, and swelled and erected body parts return to their previous state and color. This phase occurs at the end of the sexual response cycle, whether you have an orgasm or not. The couple may experience a sense of well-being, enhanced intimacy, and often fatigue. Some women may quickly return to the orgasm phase or have multiple orgasms with further sexual stimulation, although many women feel satisfied after one orgasm. After orgasm, men usually may not be able to achieve another erection or aroused again for a variable time, which is called a refractory period. During this refractory period, men cannot reach orgasm again, and this varies among men and gets longer with advanced age. Also, it is very unlikely that both partners will reach up to orgasm at the same time. Additionally, the intensity of the response and the time spent in each phase varies from person to person. Understanding these differences may help sexual partners to better understand each other's bodies and responses to enhance the sexual experience. Just a minute, I'll go to another this thing. Now this is for male sexual response. This we have seen: excitement, plateau, orgasm, refractory period, everything. During sexual excitement, the arteries dilate to rush flow of blood into the penis to create an erection. The veins are believed to contain valves to slow down the exit of blood from the penis. And this is the diagrammatic this thing. This is unstimulated state. This is partially stimulated state. This is fully stimulated state. This is skin of scrotum thickens. This is the excitement phase and partial elevation of testicles. Opening of urethra dilates. Then we come to plateau phase. Here we can see the Cowper's glands. Then twofold size increase in part of the urethra. Marked increase in size of testicles. That up to 50%, testicles fully elevated. Scrotum thickens. Testicles rotate forward. Final engorgement causes increase in diameter of glands. Cowper's gland secretion comes as a precum and color deepens. As seminal fluid collects in prostatic urethra, there is a feeling that ejaculation is inevitable. Then comes the phase of orgasm. Vas deferens contracts. Internal sphincter of bladder contracts. Seminal vesicle contracts. Prostate gland contracts. Further increase in this part of urethra, which is seen here. Rectal sphincter contracts, urethral contractions, penile contractions. Contractions force the seminal fluid through the urethra, and then resolution. Duration of this stage varies proportionately with length of excitement in plateau stages. Decreased to 50% larger than the stimulated unstimulated state, then unstimulated state. And testicles return to resting phase, size and position. Scrotum thins and folds return. After orgasm, there is a period in which males do not respond to new sexual stimulation. This so-called refractory period may be rather short in young males, but usually becomes longer with advancing age. Now I'll go to female sexual response. This is the slide. There are A, B, C, three types of response. What we are seeing. This model reflects the different responses different women may have, or an individual woman have on different occasions. For instance, now you let us concentrate on A, that is blue line. Woman A has a smooth transition from excitement to plateau to orgasm to resolution and has multiple orgasms on this occasion. Then now let us concentrate on B, that is red. Woman B or woman A on different occasion has a smooth transition up to plateau, but doesn't experience an orgasm. This is not a problem if it is an occasional occurrence. For example, it is woman A who sometimes experiences orgasm, but would be diagnosed as a sexual disorder if this occurs every time woman B has a sexual experience. Then now let us concentrate on C. Woman C has a different pattern of transition from excitement through orgasm and resolution than either A or B, again possibly reflecting the same woman on another occasion or three different women. Now we can see the changes in breast, in excitement. There is an enlargement of the breast, nipple erection is there. Then Pluto and orgasm, areola enlarges, sex flush is there, and in resolution, sex flush disappears. And after orgasm, the rapid reduction in swelling of the areola often makes it appear as though the nipple has become erect. Now changes in external sex organs at rest. Now excitement phase, clitoris increases in length in 2 to 3 times. Minor lifts increase in size and extend outward. Major lifts become separated and elevated. In Pluto phase, clitoris retracts under hood. It is difficult to locate and touching it directly may cause pain. Minor lifts turn bright red and increase in size. If stimulation continues, orgasm occurs a minute or a minute and a half after the bright red color appears. Bartholin's gland secrete 1 to 3 drops, then orgasm. Clitoris retracted under hood. Minor lifts, no specific response. Major lifts, no specific response. Resolution, clitoris slowly returns to normal size. Minor lifts return slowly to normal size and position. Major lifts return to normal. There is some evidence that females may also experience a so-called refractory period, that is a time after orgasm in which they do not respond to renewed sexual stimulation. However, this phenomena is not always easily noticed since many females are capable of several orgasms in quick succession. Now, changes in internal sex organs. Vagina, actually a collapsed tube but shown distended for purpose of illustration, begins to lubricate within 10 to 20 seconds. Inner 1/3 of vagina lengthen and distend. In Pluto phase, clitoris retracts under hood, uterus fully elevated, cervix, there is no response, vaginal barrel extends, tenting or ballooning effect. Orgasmic platform, the vaginal entrance contracts to produce a grasping effect. Minor lifts increase in size and turn bright red. Orgasm. Uterus undergoes contraction similar to labor. There is seminal pool. Vagina, strong contractions of orgasmic platform, 3 to 5 contractions in a mild orgasm, and 8 to 12 contractions in one and an intense one. Rectal sphincter contracts. Resolution. Uterus drops back to normal position. Seminal pool. Cervix drops into seminal pool. Vagina outer 1/3 returns quickly to normal. Inner 2/3 returns to normal more slowly, 5 to 8 minutes. There is some, this I told you, they generally, females are able to have multiple orgasms. Now I'll just show 2 videos. One is for male. one more video for the female this thing. This is the end of my presentation. Thank you for listening. And thanks a lot. Thanks a lot, Dr. Ritu, for giving me an opportunity. It was nice to talk to you.
Thank you so much, sir.
Congratulations, Dr. Jawar. Congratulations, Dr. Anand.
Yeah,
Very nice video.
Thank you.
Yeah.
Thank you.
Nice to meet you.
Thank you.
Sir, will you please stop sharing?
Yeah.
Sir, we have received the comments from Dr. Mukesh Patel, a nice
Yeah.
webinar, and Dr. Bashir, our president of Somalia Society. He is also writing a very nice webinar. Sir, I have received 2 questions. I received a lot, but I only will take this 2 questions. So this question is from Dr. Mujib Sheikh. He is joined from Bangladesh. His question is, what's the treatment you are giving in the patients of the premature ejaculation and delayed ejaculation in India?
You know, we are giving this SSRI for this thing, you know. Yeah. For premature ejaculation. Yeah.
And for delayed ejaculation, sir?
Delayed ejaculation, there is no specific this thing treatment
I think
for it.
counseling
You
and
know.
history taking properly is actually the solves the most of the problem.
Yeah.
So thank you so much, sir. Dr. Mukesh, the program is going live on my YouTube channel. So if you want, you can see from there also later on. So now, without wasting time, we are switching for the next speaker. And later on, we can take collectively the lot of questions we'll receive. So next talk is by Dr. Anita Madam. Madam, the dais is all yours. We all are eagerly waiting to listen to you. And warm welcome, dear madam, warm welcome.
Thank you, Ritu. Thank you for giving me this opportunity. So I'll be presenting non-communicable diseases, that life cycle approach in women. So can you see my screen?
Yeah, but the
now it is visible. So what are non-communicable diseases? They are nothing but the chronic diseases. They are medical conditions that are non-transmissible by definition, and they often require long-term treatment and have slow progress. And what are they? They are just result of poor self-management, genetic factors, physiological, environmental behavior, and other socio-demographic factors. And it is soon going to be a silent epidemic and an important cause of death in women. Why? Because it is causing premature death in women. What is premature death? It is any death happening before 70 years of age is premature death, and it has become an important cause of premature death in women. The main types are, we all are aware, cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes. Now it has been extended to cover hepatic, renal, gastrointestinal, endocrine, hematological, and neurological diseases also. And moreover, trauma, mental disorders, and disabilities have also been included in the non-communicable diseases. Unfortunately, NCDs are disproportionately affecting women, especially in low and middle income countries, where more than 3/4 of global NCD deaths are happening. And as I told you, NCD related deaths, 80% are happening because of this disease only. These are the striking statistics. In India. NCDs contribute to 60% of all deaths, and a majority, I have already highlighted, coronary heart disease, respiratory, cancer, diabetes. They are the main 4 things. And you will be surprised to know that prevalence of tobacco consumption in India is 44% in males and 6.8% in females. And this is a very important contributing cause for NCDs. And you will find that there is a rapid increase in prevalence of obesity from 9% to 18% in males, and from 12% to more than 20% in females over the years. So this was a news item 15 days back, and it states how 60% rise in cardiovascular diseases has happened, and all this is leading to more premature deaths, especially in the third world countries or the developing countries. Now, how to safeguard women's health and how to tackle NCDs? They propose large threat to health around the world, women all around the world, and 35 million deaths are happening because of NCDs, and among them 18 million deaths are happening in women. So we have to give them due attention. Cancer, diabetes, and heart disease are no longer the disease of wealthy. Today, they hamper the people and the economy of even poor populations, even more than infectious diseases, which we used to first think a great cause of mortality, and we wanted to conquer that cause of mortality. Now NCDs have taken over the infectious diseases cause of mortality. And so NCDs have really become a public health emergency. So how it affects? It is a call for action. So you see this, how to set the stage for conquering NCD. If we try to understand this chart, cardiovascular diseases is the first major killer of women in the world, and it is causing 8.6 million deaths among women annually. And cancer, if you consider 8.9 million annual cases are there, and among them 4.8 million annual deaths happen due to cancer globally. Similarly, diabetes. And if we consider diabetes, that if we consider 21 million live births are happening, and out of them, majority were affected by some form of hyperglycemia in pregnancy. So this is increasing the disease burden among the intergenerational aspect, if we consider that also. Similarly, chronic respiratory diseases are a leading cause of premature deaths, almost over 1/3. Because of chronic obstructive pulmonary disease. This is happening because of increasing incidence of smoking, then environmental pollutants. They are causing chronic respiratory problems in females also. And one important thing is indoor smoke. Like in developing countries, women are using wood and charcoal for as fuel for cooking. So it is becoming an important cause for chronic respiratory disease in women. Then depression, mental health aspect has not yet attained that much attention which it should. we must understand that this is the leading cause of disease burden among women in low middle income countries. And perinatal depression has been reported almost in 18 to 25% of women. So we must know that once considered a disease of affluence, it no more is restrained to that community. Even low socioeconomic strata women are getting NCDs. So what are the risk factors? Risk factors are many. Some are modifiable, some are non-modifiable. Non-modifiable risk factors are your age, gender, genetic factors, race, and ethnicity. While modifiable risk factors are your biological factor like obesity, dyslipidemia, hyperinsulinemia, control of hypertension, etc. Then your behavioral factors like high sugar, salt, and fat containing diet intake, lack of physical activity or exercise, increasing screen time, tobacco and alcohol consumption, all these are leading to increased NCD. Then societal factors. There is a complex interaction of socioeconomic, cultural, and environmental parameters. And one important thing is how responsive our health system to the requirement of these women. So women and girls are especially at risk, and nearly 2 out of every 3 women, they die of NCDs. I'll not reiterate it again and again. It has become a major cause of death and disability in women. And one important aspect is if a woman is suffering from NCDs, they are more prone to have health deterioration because they don't have the health-seeking behavior. So majority of women will have underdiagnosed NCDs and they will remain undertreated. So this inequity has to be taken care of. We must give them due attention, and this factor, equality and equity, must be given due attention regarding healthcare system management for women. Now, why we should be bothered about non-communicable diseases? If you see this chart, how much, what is the economic consequence of NCDs, and on whom does the cost fall on? Regarding patient will have care cost, treatment, productivity will go down, and she has a lot of pain and suffering and side effects due to that. Family also suffers. Family is contributing to the cost of the care. Then time off the work, husband will take her to the doctor for the treatment. He will also lose his wages. Then other are career burden also. Employers also suffer because the productivity of the workplace goes down. Similarly, society also suffers. So how the story of NCD unfolds over the life cycle? What happens in prenatal events? It also contributes to the diabetes and development of NCDs. We are starting from the pre-conception period or conception. What happens is if the mother is undernourished, there is delayed physical and cognitive development, and these NCDs are likely to happen in the next generation also. And one striking feature is that adult women are more likely to be obese than men, this fact being associated with rising NCDs, increased risk of morbidity, disability, and death in women. Now, why this happens? Why women suffer more? Because of the inactivity and poor access to the healthcare opportunities. They are working in unsafe environments. Poor socio-economic construct is there. They don't have hygiene facilities. They do not have access to doctors and hospitals. And moreover, high healthcare costs, lost productivity, and catastrophic expenses are brought on by NCDs. Women often are underprivileged, and they are the group least expected to afford NCD treatment, especially in poor or marginalized communities, especially in war zones. These things become very, very relevant. If you see this pyramid, what we focus upon is the base: diabetes, COPD, neoplasm, and CVT. What about the light pink? Above that is brown and dark red. These are other NCDs which we do not give any attention to. Other neglected NCDs like alcohol and substance abuse, cirrhosis of liver, asthma, chronic kidney disease, Alzheimer's and other dementias, and sickle cell disease. They are all major causes of loss of productivity and disability adjusted life years. So we are not giving attention to these upper part of the pyramid. We have to get it under the purview of our consideration. While deaths from NCD occur mainly in adulthood, they may happen in early life. They have epigenetic mechanism, because if the mother is having genes for diabetes and all that, the women's children also become vulnerable to develop NCDs later on in life. They are usually undernourished, low birth weight babies. They become prone to adulthood diabetes and hypertension. So preconception optimization of women's health is therefore very, very relevant. We all know Barker's hypothesis, because Barker had hypothesized that there is in utero origin of adult non-communicable diseases, and there is a permanent structural and metabolic changes in the fetus if the mother is suffering from these NCDs. Even maternal stress, alcohol, tobacco consumption, it also negatively influences the genetic makeup of the baby. The baby will have poor cognition later on when the child becomes adolescent or adult. What happens is, if there is hyperglycemia in early pregnancy, the fetal pancreas is preset to secrete more insulin, and development of diabetes later on because of insulin resistance. And as such, if the mother is receiving treatment for any non-communicable diseases, this adverse effect of drug may affect the fetus in utero also. Now the baby is born. What happens in childhood and adolescence? Now, suboptimal breastfeeding, unhealthy complementary feeding, because the mothers are working, the children are left with caregivers. They often opt for pre-packaged junk food for children. The child becomes obese. The adolescent becomes obese because of poor, unhealthy complementary feeding during childhood. And what happens in older girls? Many schools are now unable to promote exercise and physical activity and do not include life skill trainings. So another factor is our children have now access to high calorie unhealthy diet. Readily they get online, they can order food, pizzas, burgers, etc. And rather than getting healthy drinks, they will have aerated drinks in schools. All these lead to overweight, obese adolescents. Smoking and alcohol has considerably increased in adolescent population, and it has contributed to NCDs. Now, what happens is, if the girl is obese, there are more chances of PCOD, hirsutism, and menstrual irregularities. And there is poor body image. These issues lead to social isolation, depression, and negative impact of girl on peer relationships, learning, and opportunities to participate in educational and recreational sports activities. Now the girl has become adult. Financial stressors, unemployment, unsatisfied careers, low social engagement, all these influence the progress of NCDs in women. And it may cause, clinical signs of abnormal uterine bleeding, anovulation, infertility. All these problems, I need not, tell to this August gathering. Then there is pre-existing diabetes, hypertension, epilepsy, respiratory disease, and obesity itself increases the maternal and fetal risk during reproductive age groups. So all these things make a difference: dietary habits, genetic predisposition, and physical inactivity. One thing is correlation with cervical cancer, early initiation of sexual activity, and poor coverage by HPV vaccination, and limited use of contraception. All these contribute to the development of cervical cancer, which is an important component of non-communicable diseases in women. So we have to make the link the gestational diabetes mellitus, which affects 1 in 7 pregnancies globally, puts both women and their babies at increased risk of ultimately developing type 2 diabetes. And moreover, they had brought to the notice of doctors that women who are treated with medications for HIV, they are also more likely to develop NCDs because of their side effects. So this is one thing we must keep in our minds. Then what happens when the woman is adult? All these things get affected. She's develops cardiovascular diseases, then stroke may happen, musculoskeletal disorders like osteoarthritis, obstructive sleep apnea, and sleep disorders are, important part. Then NASH can happen, non-alcoholic liver disease, gallstones, etc., cancer, breast, cervix, ovary. All these are related to obesity, which the woman is developing. Lung disorders. And we have all learned about Karpus cancer syndrome, which was the triad of obesity, hypertension, and diabetes. Now, how do we measure obesity? Initially, we used to use BMI. Now we are using alternate measures because they are more relevant regarding cardiometabolic consequences of NCDs. We are now more into use of waist circumference or waist to height ratio. Then other methods are also being studied like CT, MRI, DEXA absorptiometry for the actual fat content in the body, and bioelectrical impedance. They are all under research. Now the woman has entered the perimenopausal and perimenopausal phase and goes to menopause. So the life expectancy has increased. Now what is happening is this woman with the NCD now has retired. She has left her workplace. It becomes a challenge to her because now she will have further poor nutrition, lack of physical activity. She will have social isolation. She won't go out. She will develop alcohol and tobacco, abuse may be there. So all these things have to be taken care of, and she should maintain a healthy weight, which can minimize the chances of her further problems developing breast cancer, colorectal cancer, etc. Besides other medical diseases like diabetes and hypertension. So keeping all this in focus, this was the agenda because it was a public health concern. In 2030 agenda for sustainable development target 3.4 of sustainable development goal, they shared that all the women should have healthy lives and promote well-being during all the ages. So they concentrated on reducing premature mortality in women by 1/3 due to NCDs through prevention, screening, early diagnosis, and treatment. And this said that maternal and child health has to be integrated. Life cycle approach should be provided to these women as a continuum of care. So this was the NCD Alliance for Call of Action for Prevention, Treatment, and Control of NCDs, and it was integrated with other health programs like HIV, AIDS, and RMNCH programs. So what are the future prospects? It has to be a multi-sectoral approach. We have to promote health in schools, colleges, workplace, healthcare practices have to improve. You have to educate the masses through IT, mass media, and promote vaccination. Vaccination are the silver bullets for cervical and liver cancer prevention, especially, which are an important non-communicable disease now. Public policies and regulations are required for tobacco and alcohol consumption reduction, improved health literacy, encouraging behavioral changes, and very sensitive, gender-sensitive health policies are to be developed. And we have to have a response care system which is bothered about women health and social security. And one must know about this National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, which has been launched by Government of India. Initially, they were separate. Now, all these things have been integrated into one program of NPC DCS. Government is initially, they were having opportunistic screening, whatever patients were coming to you, women were coming to you in adolescent clinics or reproductive clinics, they used to be screened for NCDs, but now they target that the screening should be community based through ASHAs and ANS. So we must know these national programs. So carry home messages is that good nutrition and health optimization of women is important throughout the life cycle of the women. And first 1,000 days are very, very important. If the child is given proper attention during first 1,000 years with proper breastfeeding and healthy complementary feeding, we might avoid development of NCDs later on in their lives. Then behavioral changes are required, as I've already highlighted during childhood, adolescence, regarding exercise, avoiding drinking and smoking, and timely vaccination for these girls. Then structured screening, early diagnosis, prompt treatment at various wellness centers, as is a dream of our current Prime Minister, and proper preconception and perinatal care of women. So these interventions will be more cost effective in women rather than treating them throughout life. We must prevent development of NCDs rather than giving them treatment lifelong, and then only we can achieve the global strategy for survive, thrive, and transform. So thank you so much for giving a patient listening, and I'll seek your blessings for Chairperson NCD Committee FOXY. So this is, my passion, and hope I will be able to contribute to FOXY and FOXians regarding that. Thank you so much.
Thank you, madam, for such a brilliant lecture. And madam, from all of us, our side, the best wishes for your upcoming elections.
Thank you,
Madam, you have shown one slide regarding the prevention for the cervical cancer and the liver cancer, the silver bullet. So that is very informative. Cervical cancer, we all are aware. We all are giving. Can you enlighten something about this liver cancer? Because
we all know that. Actually, we don't pay attention. Vaccination against hepatitis B.
Yeah.
It's so simple. And hepatitis B is one of the major, contributor. It leads to chronic hepatitis and then later on development of malignancy. So even when I was preparing this, I was also, stricken by this fact that these simple measures like vaccination against cervical cancer and vaccination against hepatitis B can go a long way in prevention of at least liver cancer and cervical cancers. Isn't it?
Yeah. Thank you, madam.
They call it a silver bullet. They are very effective measures. Yeah. Thank you so much for giving me this opportunity.
Thank you, madam. So friends, now we are moving towards the last talk of the day, which is none other by our Dr. Kishore Rajurkar sir. Rajurkar sir is very famous. Sir is always giving us some tips, tricks in the Ops Dynamic discussion group. So it was my long-term wish to get the sir in one of my program, but somehow kabhi time nahi match ho pata tha somehow. So today really I'm very happy to have a sir with us on my platform. Sir, a very, very warm welcome to you, and we all are eagerly waiting to from you about the IUGR. I know sir's talk are very practical. Sir is going to highlight some practical points.
Thank you, Ritu, for inviting me in this prestigious webinar. I just want to make a few comments about the two earlier topics which were there, Dr. Anand and Dr. Anita. Dr. Anand has touched upon a very important aspect which is not generally discussed anywhere. And I being now the president of the Delhi Society of Vaginal Surgeons of Delhi, so actually the sexual aspect of obstetrics and gynae is also very, very important, particularly when we do some vaginal operations. And the second thing about the Anita's lecture, it is non-communicable diseases, but the most important thing about them for prevention is communication. Communicable is but non-communicable, but communication is very, very important for that. and teaching is very
True, sir. True.
important. And like सुन रहा था तो ऐसे लग रहा था कि सबके सब मरने वाले हैं कि क्या हो रहा है, but I इतना ज़्यादा depressing नहीं है picture, because particularly for females, if you see the sex ratio of females of 70 years, it is 1100 females for 1000 males. For 80 years, it is 1200 females for 1000 males. So therefore, it's a good picture for females. Now my topic is IUGR. So I am IUGR, or now it is called as FGR. So I'll just share the screen.
Yes, sir. Yeah. Dr. Pulak, you please wait. Once the sir talk is finished, I am going to take some questions. Some doctors are pinging me constantly. Their questions they have not taken. Yes, sir. Over to you. Yeah.
So, I think now you can.
No, sir.
I think I'll just. I'm sorry, मैं गलत presentation कर दिया यहाँ पे.
No problem, sir. No problem. You can take your time.
Make it, I'm not that computer savvy, na.
No problem, sir. You can take your time. Anina, madam, meanwhile, we can take the one
you
question.
Can take the questions. I'll just.
Yes. The
that.
same thing I'm doing. Anita, madam. Madam, our dear friend Dr. Pulak Deka has joined. He is asking, madam, please explain the obesity and PCOD management approach.
A very important correlation, which is the root cause. It is difficult to say whether PCOS is causing obesity or the obesity is leading to PCOS. It is a vicious cycle. So management of PCOS, especially in obese women, the main underlying will be the weight loss. So it is very easy to advise. You say to the patient, 10 kilo kam karke aana ya lose 5 kg. So gradual weight loss is suggested. Good, good 30-minute exercise for 5 days in a week is important. And besides that, if they are having menstrual problems, you have to take care of these menstrual problems with either using low dose oral pills, or if you feel that the patient is very obese and morbidly obese adolescent girls, they are not able to lose weight, even bariatric surgery is advisable. One important thing will be hirsute obese adolescent girl. So they have to give in management for hirsutism also. And body image issues are very important in these girls. We have to take care of their mental health. That becomes very, very important. So all the factors taken together will make a good management strategy for these obese adolescent girls who are having PCOS. And Ritu, PCOS is a lecture in itself, and
Yeah, ma'am. Yes.
So many aspects.
Yeah.
Everything, mental, social, physical, all these aspects have to be taken care of them. And life cycle approach is very important. PCOS continues throughout the life. It's not only adolescence. Through adulthood also, you have to keep them under observation regarding development of hypertension, diabetes, endometrial cancer. So many other problems are there. And the treatment or the management is chronic, and it is right up to the old age. So they have to be under your care. So
very true.
If I could put it in a nutshell, that is the way we manage our PCOS patients.
Thank you. Thank you, madam. Dr. Pulak, here now, once the patient asks, I always explain them, see, if the nutrition is king, the exercise is queen. So once they have to win the kingdom of the PCOD, they have to keep a balance in between them. So Baki, very nicely, Anita madam has mentioned us. Thank you, madam. Tarni madam wants to say something. Madam is there. We can take madam's expert comment. Tarni madam, are you... Tarni, sir, you are ready? Kishore sir? No, I think Kishore sir is not online. Tarni madam? Madam, you are muted. Madam, you are muted. Yeah.
Yes.
हाँ.
वो डिस्कनेक्ट हो गया तो मैंने म्यूट कर दिया था, मैं
अच्छा,
उसको ठीक कर
ओके
रही
ओके.
थी। यस। अब किसका चल रहा है? डॉक्टर किशोर का ना?
आप
अनीता का
डॉक्टर
मैंने सुना।
जी जी, आप डॉक्टर किशोर का स्टार्ट करने जा रहे हैं IUGR पे मैम. हाँ.
रितु तो बहुत, रितु do really very hard work, and today you are looking awesome, awesome.
Today तो I came run. Anyhow, thank you ma'am. I just came running only 2-3 minutes earlier only the webinar. Directly I'm sitting here. Friends, meanwhile, tomorrow afternoon 2 to 4:30, we are having one webinar on this mixed bag again, one webinar that is accredited by the 1 MMC credit point. There I am going to speaking on the ovulation induction in IUI. The other two speakers are going to speak on the broad ligament fibroid and others on the adolescent contraception. So that webinar is also totally free, no registration charges, and we have accredited with the 1 MMC credit points. I already posted the link on of my social media, so all of you are welcome to join that also. Kishore
Yeah,
sir?
we will try.
Kishore sir? We can do like that. Sir can say some salient points without showing the slides, no problem. Meanwhile, friends, if any questions, please write it down here so we can take the questions.
कोई आए या ना आए, हम एक छोटी वो वर्कशॉप है ना, पब्लिसिटी कर लेंगे टिपर प्लस की हाउ आई डू इट, ठीक है, और कोई आएगा तो आ जाएगा, नहीं हम अपनी बात छुट्टी पाएंगे, ठीक है। 3 केस एक साथ
थैंक यू मैडम, थैंक यू सो मच मैडम। सर की आवाज आ रही है, सर से भी बुलाइए, मिलवा दीजिए ना, सर की भी ब्लेसिंग्स लेते हैं हम लोग।
अच्छा
हाँ
वो फोन पे बिजी है, अभी बात करेंगे फोन पे।
हाँ
प्रोग्राम बना रहे हैं आज का,
तो सर की भी ब्लेसिंग्स लेते हैं हम लोग।
हाँ अच्छा, मेरा वो अनम्यूट नहीं हुआ है।
किशोर सर,
और क्या समाचार? एक सजेशन, अच्छा एक सजेशन दो, मैं उसको पूछता हूँ।
सर ऐसे ही बता दें हम अपने फोन में।
तो मैं बोल रही कि सर ऐसे ही बता दें, कुछ पॉइंट्स है ना। हाँ सर का फोन भी नहीं लग रहा है, मैं लगा रही तो जा ही नहीं रहा है। हाँ। Dr. Abdullahi, you have joined from where? किशोर सर हो गए।
Dr. Kishore is not there, probably Dr. Ritu.
He's there. He's there. Yeah, है ना? Yeah.
So I'll show you. Meanwhile, I'll show you a presentation just for 2 minutes.
No problem. No problem. Okay. Otherwise, Kishore sir, you can give us some salient points.
Dr. Kishore is there, then no problem. Let him come. He has started screen sharing. Wow.
Yeah.
Hello.
Yeah.
Can you listen?
Yes.
Actually, I'm very sorry. My Chrome crashed and I was not able to. Then again, I rejoined. I'm very sorry for the delay.
No problem, sir. Sir, what I'm suggesting, sir, otherwise you can share us with some salient points. If it is problem in sharing,
No,
you
no,
can
it's all right.
share us.
Now it is on. It is on. It is on. It's on.
Okay,
So
okay, sir. No.
I'll be quite brief and just salient features only I'm going to tell you.
No problem, sir. No problem.
FGR is a very big. So now I think we all know about the definition. Definition is basically it is a fetus which has not achieved its genetically determined potential size. So any fetus which is genetically, जैसे अगर उसको 2 kg का होना था, नहीं हुआ 2 kg, तो it will be a FGR baby. But if the genetically उसको अगर उसको 3 kg का होना था और वो हुआ 2 kg, तो definitely it is a FGR baby. Now, and what is a small for gestational baby? Any baby जिसका growth potential 10th or less than 10th percentile of the weight, estimated fetal weight है, at that particular gestational age, it will be a small for gestational age. So now the difference क्या हुआ दोनों के अंदर? Not all the fetuses which are SGA are pathologically growth restricted and maybe constitutionally small. A small mother which is only weighing 35 kg, she will have a small baby. It is a 2 kg, but it is not small. It is not an IUGR baby. But not all the fetuses that have not met their genetic growth potentials are in less than 10th percentile of the estimated fetal weight. Now let us see if there are 100 fetuses, only 40% will have are at the high risk of potentially preventable parental death. These are the ones which should be our action may be required, and these are the one which we diagnose an FGR. Out of that, 140% will be constitutionally small. हमें कोई action required नहीं है. उसमें सिर्फ यही problem है कि that you will diagnose it an IUGR and you will induce that patient and then you will have a preterm baby, which was not necessary. And बाकी के 20% क्या है? बाकी के 20% हैं which are because of the intrinsic factors like CMV infections, chromosomal, alcohols, and all those जो हम पहले symmetrical IUGR कहते थे वो हैं. Now we do not divide them at symmetrical and asymmetrical. So the इसके अंदर we cannot do anything. Most of the time.
Sorry to disturb you, sir. Your slides are not displaying.
Oh.
It is only mentioning the Zoom. So otherwise you can stop sharing and you can speak, sir. No problem.
Okay. I don't know.
Huh.
I'll take. Okay. I'll just.
Only just stop sharing and you can discuss. We can discuss.
Okay.
Yeah.
Sorry.
No problem, sir. Don't say sorry. No
what
problem.
is going on? I don't know. So I'll stop sharing.
Yeah, sir.
Mridul?
Sir, your slides were not sharing.
Not visible. Yeah. Same thing I told Saiti.
Can I speak only?
No problem, sir. No problem.
Because I'm not able to.
No problem. Meanwhile, friends, if you are having some questions related to this topic, FGR, please put your questions in the chat box.
So I think out of 100, only 40% will require your attention, and in which you can do something. On the 20% you cannot do, and in 40% you have to not do something so that you do not develop a preterm baby. Now, why the small for gestational age babies are important? Because they form about 50% of the stillbirths, and about 72% of the unexplained fetal deaths are because of SGA, which are less than 10th percentile of the growth. So that is the importance of detecting an IUGR. Now, about 26% of the pregnancies in India, I'm giving the Indian statistics, are an FGR babies or SGA babies, out of which 40% will have IUGR. Now, what are the causes of FGR? I think we all know the causes. They can be maternal and the placental or the umbilical cord causes, and the fetal or the chromosomal causes. So maternal causes may be chronic hypertension, PIH, CHD, and the hemoglobinopathies and smoking. Now, the why I'm talking about the smoking, because this is the only factor जिसको रोकने से IUGR, you can help the IUGR. Otherwise, the treatment of IUGR is, there is no treatment of IUGR. It is only we have to decide when to deliver the baby. And then about the other placental causes may preventable thoda sa hai, we can say about the placenta previa. Our practices of delivering the patients and our practice in doing cesarean sections, for limiting the cesarean sections and then trying not to mop the uterus inside, all these to prevent the infection and to prevent the placenta previas. So these are the few factors in which we can prevent the IUGR, but most of the time we do not have any treatment for that. Now, जो fetus है, जो उसका जो growth है, how कैसे growth होती है? कोई भी fetus, normal fetus कैसे grow करता है? Up to the 16 weeks, it is mostly the hyperplasia. Then 16 to 32 weeks, it is the hyperplasia and hypertrophy. But after 32 weeks, it is only the hypertrophy. There is no hyperplasia. So that also you should know when to act. Now, we all know the major risk factors. Most of the time, it is more than 40 years of the age smokers. If you are smoking more than 11 cigarettes or 5 बीड़ी अगर पीते हैं, then it is a significant thing. And but it doesn't mean कि आप 4 पी सकते हो. Stop smoking if you are smoking. Previous IUGR or SGA baby, previous stillbirth also, such patients are high-risk patients for IUGR. So therefore, you should suspect IUGR in these patients. And another important thing is uterine artery Doppler. जब आप 24 weeks में आप करोगे, that is a very, very important for the notch. So if the notch is there, then these are the patients who can develop IUGR. Now, to know or to discuss or to manage an IUGR, unless you know the fetal circulation, it is not very easy to understand why IUGR will develop. Now, there are two shunts, we know that. The DV and the DA, I mean, ductus venosus and the ductus arteriosus. So the ductus venosus from the left umbilical vein, it will go to the IVC. So there is a liver bypass will be there. And similarly, the PA will go to the descending aorta, so the lungs will be bypassed. So if there is जो foramen ovale है, which will allow the blood from the right atrium to the left atrium. And when there is an fetal like hypoxia, what will happen? There is a reflex redistribution of the fetal cardiac output, and there will be आपके जो important organs हैं, they will be shared, and that is reflected in your Doppler studies. So हमें सबसे important क्या है? How to diagnose an IUGR? Suspect तो हमने कर लिया by all these factors. How to diagnose? So there is a very important general examination is also important, but most of the time you have to take the help of a Doppler studies. But you can always suspect how by general examination of the patient. अगर cachexic है या I mean anemic है, all these things you are pointing out towards an IUGR. Then the symphysofuntal height, it is a good measure to see from 18 weeks to 34 weeks. It will correspond in centimeters. If it is 18 weeks, it will be 18 centimeters. If it is 20 weeks, it's 20 centimeters. 34 weeks ke baad it will not. Okay. So, but it has got a low sensitivity, but at least you can suspect. But, and the most important thing now is the ultrasonography. Without ultrasonography, you are not able to diagnose an IUGR. So, uske liye sabse important kya hai? Dating scan has to be there. Fetal age has to be assigned from 6 to 13 weeks. That is the most important dating sign, because everything, your growth of the baby, measurement of that will depend on your first scan. So, and what will you measure? You will measure the fetal size, weight, then head circumference, then AC and FL. These are the three more important things which you are. Now, the most important thing is not one measurement. Nobody can diagnose an IUGR by doing an ultrasonography. अगर वो लिखता है, उसके पास कोई और ultrasound नहीं है, अगर वो लिखता है IUGR, that is wrong. Unless there is a fetal biometry at least for 3 weeks apart, and there is a lag, only then you can send. Second thing which we can diagnose is using a Doppler. So Doppler may Doppler is used in many gestational age, starting from the first trimester, second trimester, and then where the uterine artery is used, and then umbilical artery and the middle cerebral artery. These three vessels are studied most of the time. Ductus venosus is also studied, but these three vessels, if you know, then you'll be able to diagnose that. And now, what are these Dopplers? What are they going to tell you? Now, if you want to understand the Doppler studies, you must remember one thing. जो भी normal pregnancy में uterine artery Doppler, it will from the low peak flow velocity से वो high flow velocity में जाएगा. So there will be when you do a Doppler, there will be an early diastolic notch. But when you do it later on after 20 to 24 weeks, there will be no diastolic notch. So अगर diastolic notch present है, then again it is pointing towards कि आगे something is going to happen. Now, जो आप Doppler studies करते हैं उसमें आपने लिखा ही होगा PI, RI and SD ratios, CPR and all these are things are written. इसमें अपना सबसे important है this thing PI, ठीक है? So pulsatility index is the most important. Resistivity index is not used much. SD ratio is also not much. CPR अगर ये दोनों चीजें आपको पता है and you are able to diagnose, then you can study the Doppler very well and you can also predict कि इसको IUGR है या नहीं है. I'm very sorry because यहाँ पे I can't show you anything. But as I have already described about the uterine artery Doppler, then when you come to the umbilical artery Doppler, this is a very, very important Doppler. Now, what does it study? It will study the placental site. मतलब अगर umbilical artery is the main supply, placental site is studied by this umbilical artery Doppler. इसका importance क्या है? इसकी importance है both diagnose करने में भी और prognostication के में भी. मतलब एक तो diagnose कर ले है कि नहीं, and then whether you want to deliver or not, that will depend solely on the umbilical artery Doppler. It will not much depend on uterine artery Doppler or even MCA also. So this is a very, very important Doppler study. Now, एक और चीज, whenever you see any picture, जैसे आपको Doppler ये ultrasound करके देते हैं, you please see diastolic flow है कि नहीं. Systolic flow तो आपने देख लिया, diastolic flow है कि नहीं, that is very, very important. Diastolic flow होना चाहिए. अगर diastolic flow नहीं है, तो it means the resistance is increasing and there is something to worry. एक तो उसके बाद diastolic flow नहीं होगा, then it will be an absent diastolic flow और ज्यादा problem. उसके बाद स्टडी होगी, it will be a reverse diastolic flow. Reverse मतलब नीचे उसका जो ग्राफ बनेगा वो इंस्टेड ऑफ ऊपर का ट्रायंगल की नीचे ट्रायंगल आ जाएगा. So that is very important. It means there is an acute deterioration and it is an immediate indication of delivery. Now, when you study a growth of the baby after 30 weeks, the risk of stillbirth in a fetus with an isolated EDV in umbilical artery Doppler overcomes the risk prematurity, and therefore you must deliver. Don't wait, otherwise you will have a stillbirth. Now, when you come to the MCA Doppler किसके लिए? MCA Doppler is basically to study the fetal side. So it will, what it will tell? It will tell about the brain vasodilatation, and because of that, it is also a surrogate marker for the hypoxia of the baby. But the problem is that it is a late manifestation. Late manifestation. Hello? Can you listen? Hello?
Sahiti, can you block this person?
Yes, ma'am, I'm trying.
Please, I think it is hacked. Kishore sir, you can continue.
Dr. Kishore has muted himself, I think.
Yes, sir. Sahiti, you blocked that person?
Yes, ma'am.
Yeah, okay.
Sir, you are muted, Kishore sir, you are muted.
I think when Kishore sir will come, we will take these questions and we will wind off. Already 10:30. Yeah.
Yes.
Kishore sir, you are muted. Kishore sir, you can join from your mobile if it is problem coming from laptop.
Okay, that I could have done, yaar.
Yeah.
You are audible now. You are audible now.
Okay.
Sir, you are audible.
Achha, can you just see whether I can share or not? Let us see.
It is coming, sir.
अब मेरी slides आ रही हैं?
नहीं, slides नहीं दिख
slide नहीं आ रही सर, मैसेज आ
Join
रहा है.
meeting आ रहा है, join
Not
meeting.
yet, sir.
पता नहीं
Join
क्या
meeting आ रहा है अभी.
सर आप वाइंड कर लीजिए आप अपना. Technical glitches are part of it. Yeah.
Actually, आयुष ना थोड़ा सा मुझे दिखाना बहुत जरूरी था, वो ऐसे कुछ समझ में नहीं आएगा ना.
Sir, meanwhile, I will take 2 questions for you, sir.
Okay.
Sir, the question is for a friend from Dr. Pulak Deka. He is joined from Assam. He is writing, sir, please share the management protocol for IUGR, role of arginine and role of sildenafil.
Yes, it has come.
Now your slides are coming.
Are they coming?
Yes.
So should I finish it now and then we can take it, the questions?
Yes, sir.
Okay, no problem, sir.
Okay. Actually, it was a Now, okay. So I think we were at MCA Dopplers, and so it will tell you about the vasodilation. देखो ना, अगर MCA Doppler में आपको अगर there is when it is showing that this is basically a phenomenon of redistribution, because this is brain is a very important organ. So agar if it is it is going to predict, and most of the time it is going to predict your late onset FGRs, and it will be very, very important for the umbilical artery to form. And if there is MCA Doppler is showing that there's an effect, and then the cesarean section rates will become very high. But again, it is not going to tell you when to deliver. Umbilical artery Doppler is the most important. But another aspect is the CP ratio. So it will improve the MC and the umbilical artery alone. But if it is an increased placental impedance, it is associated with the reduced cerebral resistance, and therefore the CPR is very, very important. And it should always be more than 1, as we all know. And जो late SGA fetuses हैं, they have an abnormal CPR in about 20 to 25% of the cases. So therefore, not in all. So, but we will have. Then ductus venosus is another important Doppler study, which is a single most strongest Doppler parameter to predict whether this baby is going to die soon. So it was going to predict in about 90% cases it is abnormal 48 to 72 hours before the BPP. So therefore, now these are the graphic representation.
Sir, you can move the slide.
We can, but I think this is an important thing in which you can predict if you have a Doppler of an umbilical artery PI, how much time or days you have for delivery. So there you can see now the DV, if it is reversed, then it is only 1 day. And if you have an absent umbilical artery, you have 10 days. And therefore, these abnormal CPR, again, you have 2 weeks. And we should also know why the early and the late FGRs, they have different, and the management is also different. And most of the time, when it is a late onset FGR, it becomes a diagnosis problem नहीं होती है, and but management हो जाता है. पर इसके अंदर पहले वाले में diagnosis because it is a management problem because the gestational age is low. So I think we can biometry, we should do it every 2 weeks, and the Doppler studies, it will all depend on whether it has to be done weekly, sometimes bi-weekly, and sometimes daily also you may have to do it. So if it is a fetus of 24 to 28 weeks, if it's an abnormal Doppler, again counseling and discussion with the family, because you cannot, if you deliver also the survival rates are very low. If it is an arrested or reverse Doppler studies, or an abnormal DV, then abnormal BPV, then you have to deliver giving steroids and deliver. And if it's an arrested growth like or oligomeninges, also they are 30 to 34 weeks. So 34 weeks में आपको डिलीवर करना ही पड़ेगा अगर IUGR अगर आपका या FGR डायग्नोज्ड है तो. आपके what should be the aim of delivery? A live fetus with intact survivability. And आपको ये balance करना पड़ेगा whether the baby has to remain intrauterine or it is better to come that it is outside. But again you have to balance, prematurity नहीं होनी चाहिए उसमें. But if it requires to be delivered, it has to be delivered. When to deliver, I think we have already discussed. But the most important thing is the perinatal survival at that particular gestational, it has to be discussed with the patient and the relatives. But it is very, very important that even every day is very, very important. जब 32 weeks से कम है, every day is very, very important, because if you gain 1 week, the outcome will improve by 40%. And in this, the venous Doppler will be of a great help. लेकिन अगर 32 to 34 वीक से स्टेरॉइड दीजिए एंड डिलीवर करा दीजिए अगर अम्बिलिकल आर्टरी के अंदर रिवर्स फ्लो है तो. So what should be the mode of the delivery? It will depend on the parity, cervical score and everything. But the vaginal delivery only for the well-compensated baby with reassuring fetal well-being test and with diastolic flow. अगर diastolic flow नहीं है, immediately take it for cesarean section. Do not take any risk. कोई antenatal treatment available है? There is no antenatal treatment available. IV fluids only if it is a dehydrated patient. Otherwise, there are no amino acids. हम देते रहते हैं, large and सब कुछ करते रहते हैं. There is no effect. Aspirin, if it's only for the PIH patient or preeclampsia, which is also it is not effective for the late onset PIH. It is only effective for the early onset PIH. And if it is indicated heparin, otherwise it is not. There is no treatment available for this for treatment except for smoking. You can avoid cigarette smoking. So if you want, I can have some cases are there. But I don't know whether time is there for that. You can take up the questions, I think. Hello?
Ritu?
Or you want?
Yes, I am here only.
What do you want? You want cases or you want?
No, sir, I think we will take these 2-3 questions, and then we will wind up. It's already quarter to 11.
It's already. It is all my fault. It is my fault.
No, sir, please. No, sir, please don't say like that. No, sir. Sir, please, the question of Dr. Paul Deka, because he is the first person who has joined today for our webinar. So he wants some information regarding this role of arginine and sildenafil.
Actually, we have studied all these in very double-blind studies also. There is no role of anything, neither arginine, nothing. There is no role of anything because just imagine why there is an FGR. If it is because of the maternal and PIH, or if it is because of the placenta, how these are going to help? No? They are not going to help you at all because the pathology is totally different. So therefore, all the studies have shown it has only जो studies दिखाई गई हैं वो smoking avoid करने के बाद उनका IUGR थम गया है और dehydrated patients को हमने IV fluid दी हैं तब है. Otherwise, but everybody does it routinely. सब alginate sachet देते हैं, मैं भी देता हूँ because the patient has to psychological thing basically, but otherwise it has got no role.
Okay, sir. Thank you so much, sir.
Okay.
Tarni madam dropped me a message that she wants to say something. Madam, are you there? Tarni madam? Meanwhile, thanks a lot for my today's esteemed speakers, Kishore sir, Anita madam and Anand sir. Thank you for joining. If Tarni madam is joined, then we can take her comments. Friends, meanwhile, if there are any questions, you can put on the chat box or you can put on the YouTube. I will try to collect the answers from the speakers and will post there. And I think today it's very late. It's 11:45 and Saiti has to run a lot of... Saiti is our technical team support from the Shield because from the morning, this girl was on the webinars. So, friends, thank you. Thank you once again for joining. With this, we will wind up for today's session. And thank you, dear friends who have joined.
Thank you, Ritu. Thank you for giving
Thank
us
you.
that.
Thanks, Dr. Ritu. Thanks,
Thank you,
everyone, for
Thank
patient
you, Ritu.
listening.
Thank you for
Thank you.
tolerating it, all these things.
Thank you, sir.
Thank you to all the delegates and the
Okay. Thank you.
support. Thank you so much.
Thank you.
Yeah.
Good night.
Good night.
Good night.
Good night.
Good night.